TIA is like a warning for a stroke?
Read it all. What?
I don't have to.
Yeah, I know. Hey.
Go, Brooklyn, go. A TIA is like a mini stroke, it's like a warning, I guess.
What? A warning stroke, or what I say yesterday, a pretend stroke, which is not true.
Somebody else has got the side.
It's mini stroke warning. So what's important to why do we need to know about a TIA? So what are we doing as a nurse? Just say, no, you're gonna have one day, go ahead. No.
Education.
What kind of new ways are they gonna adapt?
Diet.
Lifestyle,
No smoking.
cholesterol, what kind of medication?
Hypertension. Make sure you take
Diabetes, be
diabetes.
compliant with your diabetes.
Do you get TPA for TIA?
No.
No. Non-contrast CT.
So will it show?
How do we know it's a TIA?
But if it depends on, is it from AFib, because then you wanna put them on anticoagulant,
Good question.
exercise.
I have a question. So if a patient comes into the ER with like stroke-like symptoms and it really is a TIA, how do we know that it's a TIA if the symptoms haven't resolved? Do we still give TPA?
So if they're still having, if they're still having symptoms like in the emergency room and past like that 15 minutes, they don't have any symptoms resolved, then they'll start TPA as long as it's not a head bleed.
Okay.
So usually, usually the few minutes with a TPA, it most errs on the TPAs within a few minutes those symptoms resolve. But they say within a few minutes to 24 hours.
Okay.
Weakness on the right side is on the left side, left brain stroke, and vice versa.
Left side is the logic side, right side.
Left side is the logic side, smart side. I worry more what's going on in the lobes, right? We have to know what's going on in the lobes. Intracranial pressure, tell me about that.
When you have the monocaloric hypothesis,
The earliest sign is the decreased dose.
Okay.
King.
What is
Because of the 30 degrees.
That's right.
Had it been 30 degrees?
Yeah.
What are their symptoms?
less contraindicated.
Low respirations, low pulse,
We have to manage.
and high blood pressure. JR,
Yeah.
all those are. What's that called?
Cushing's triad.
Cushing's triad.
Good.
High blood pressure, extremely high blood pressure, low pulse, low respiration. Opposite of shock.
Opposite is what?
Opposite of shock. What else do I need to know about?
Monocaloric hypothesis.
That's just a nice to know thing.
Are you serious?
It's the concept that if something increasing within the brain is gonna cause increasing cranial pressure. All right, TPA, do we need to go over TPA or do we have it?
4.5 hours.
Do we need to go?
Make sure you have 2 minutes.
All right.
Before you do it.
Before you do it. And know it lines after.
And know what?
No, like, other lines, like only.
Is that nice to know stuff or?
It's good. No, I just.
We had this discussion yesterday. It's nice to know stuff. What's the most important things to know about TPA? 4.5 hours, bleeding, we're going in, we're anticoagulating everything. What? major surgery, because what's gonna happen, I just had an abdominal surgery, and now I'm having a stroke, and now I'm getting TPA, and now my wound is opening up, and now I'm bleeding out, and I'm gonna die.
Over 80.
Over 80, I know. Something else, there's one other thing. Yeah, hemorrhagic stroke,
INR.
INR, 1.7 has to be over. Okay. Anything else? Autonomic oh.
I feel like I don't know that word. Automatic.
What about why, we said the 4.5 hours, why are we not giving TPA past the 4.5 hours?
We can't help them anymore. It's too damaged.
Risk versus a reward, the damage is done, all we're gonna do is increase more damage or more risk factors to you. It sounds harsh, but it's true. Alright, what's autonomic dysreflexia? What kind of injury did they have? Spinal cord injury. So what is happening, where is the miscommunication in autonomic dysreflexia? It's kind of in the name.
Autonomic system?
The autonomic and the well, it's in the autonomic nervous system. There's miscommunication between the sympathetic and parasympathetic nervous system. Because one is saying, hey, you gotta vasoconstrict, but that message is not getting there. Or vasodilate. Is that an autonomic dysreflexia? So what's the problem with autonomic dysreflexia? What is a patient experiencing? Not diaphragm. What's happening? We have to investigate. So I'll tell you a story. I had a student, I think I told you this. I had a student in clinic. I'm afraid about this. So I had a student in clinical once and extremely high blood pressure. And so the nurse and the student are kind of getting involved in whatever. They need help. They didn't really need help, but I was getting involved because students was going to start doing some IV pushes, some hydrolysine, whatever. So I go in, the guy's face is red, he's sweaty, and then, I don't know why, but we took the blankets back and he's got these tiny little white legs. And if you've seen like a spinal cord injury or something like that, there's like no muscle development lower extremity. So I'm like, something's going on here. This picture doesn't make sense. Well, come to find out, he was in a motorcycle accident 20 years ago. So he was experiencing autonomic dysreflexia. His bladder was full, so we emptied his bladder, his blood, but he was like pale legs. It was a totally textbook situation. And we emptied the bladder, we did give him some medication, but we sat his head up bed up first because his blood pressure was high, and then we investigated. So other issues with the bladder, with autonomic dysreflexia, there's a couple of other causes. Fecal impaction, so that means we gotta go up and find it, see if there's anything in there. Hypertension is a medical emergency, so because their blood pressure is so high. What did you say? Oh, you said it? Okay. Oh, restricted clothes, you're right. Both of you are right. Restricted clothing, full bladder, fecal impaction, pressure areas, any skin issues or anything like that. Okay? And do I what? Skin, like the pressure area, maybe they got an ulcer on their butt. Like on their left.
She
Healing, stressing, yeah, I mean, it, right, right. Well, you could treat it and stuff. Okay,
No.
14 afternoons.
We
What
already-
are symptoms?
We already did last time.
Neurogenic
Opposite of
shock.
Cushing's, right?
Everything's down. Everything's down. Respiratory rate, blood pressure, because it's shock, remember. So this time the blood pressure is down. What caused that neurogenic shock?
Hard problem.
A spinal cord injury. So. UTI. Does that, how could that, or what? Sorry. What do you wanna know about the UTI? What could it cause? Dysreflexia, yeah, I thought you were going into shock. Because what type of shock would they be at risk for with the UTI? Septic shock, yeah. Okay, we okay? Any questions about last week?
This is the main.
Yeah. Okay, why, go through back pain because it's spinal cord, but there's, different acute back pain and chronic back pain, and what I really wanna hone in on the back pain is really the surgical, measures for back pain. But there's a couple different types of back pain, herniated disc, lumbar disc, and, degenerative disc disease. There's always a type of, I think you'll know what I'm talking about. The pain, depends on where the location is in the back. If it's in the lumbar puncture, is it in the thoracic, it really just kind of depends where the pain is or where that bulging disc is or whatever. Prevention is your best measure, so ergonomics, you'll have to do competencies every year, wherever you work, on how to lift, keep your back aligned, make sure you do good ergonomics, posture, exercise, make sure you wear low-heeled shoes, healthy weight, no smoking, all preventative measures. So there's non-surgical management, the first one's acute low back pain, which is you could do Tylenol, firm mattress, Williams position, where you're getting the pressure off the lower back. So they might be laying flat with a pillow under their knees just to take the pressure off. Chronic low back pain, you might gabapentin. If you see that for any kind of neurological problem, gabapentin, I figure is ordered. We see that a lot, and I saw it actually yesterday. Heat therapy, physical therapy, weight control, and any kind of complementary alternative therapies. They even talk about chiropractic therapies.
That works.
I tell people not to go to a chiropractor.
I went and it worked. I said I just got off my 6 weeks of treatment there. I don't feel like I was feeling, cause I had an accident on the 27th of August, and I ended up just going like 2 weeks after, and I feel like something just pushing me down on my shoulders, my head, my neck. I don't know what he did, but he did several things. Yeah, it's gone. But he did an X-ray, and he said I had disc 6 was like not good.
Oh, really?
Yeah.
Um,
My disc 6.
biggest thing, gabapentin, I would say, and then the Tylenol. What is our max for Tylenol? 4,000. So we gotta always pay attention to those numbers. So there's 5 different surgical incisions. I think if you see an ectomy, you'll realize it's a surgical or removal. Yeah, you'll recognize that it's a back surgery. You'll see an otomy, and then they have if you look at the back, or the last part of the word, they all have ectomy. So laminectomy, microdiscectomy, all that. But what's important to know is the care postoperatively. So because they're having a spinal cord surgery, we want to make sure we're doing those neurovascular assessments. We're checking the cap refill in their toes. We're checking can they move their toes. Are they warm and tingly? Or are they warm, not tingly, no pain? So do those we're monitoring that dressing, so because it's in the back, we're looking for cerebral spinal fluid. Is it just clear drainage, or does it have a halo? If it has one of those, we need to make sure that, we're checking it for glucose, because glucose is not stored in the cerebral spinal fluid. Log roll the patient, so we wanna keep body alignment, so usually there's more than 2 people. But log roll, pain control, patient positioning and mobility. There's strict instructions on, when they get discharged. It usually depends on the type of surgery that they have, and, just kind of, for post-surgery, we're worried more about this. Can they avoid? Do they have control of their bladder, and, are they able to avoid? Post-education, they'll usually, if it's a minimal invasive surgery, they can usually resume activities in a few days to up to a couple of weeks. Shower in a couple days. Usually they have steri strips on there. We tell them not to remove those steri strips to keep the incisions closed. Keep them in place, they'll fall off eventually. And then if you see clear drainage, make sure that they're contacting their surgeon immediately. Conventional open back, this is more invasive surgery, where they might have driving or activity restrictions for a few more weeks, like 4 to 6 weeks. Limit daily stair climbing. So if they have bedroom on the first floor or on the second floor, they might need to move downstairs for a couple weeks. Restricted driving, do not lift heavy objects, more than 5 pounds. Restrict pushing and pulling activities, even something as minor as walking a dog. Because if you think about it, you're walking a dog and the dog takes off, you're getting pulled forward, especially if it's a bigger dog. Avoid bending and twisting at the waist, and then take daily walks, keep moving. But you've gotta monitor alignment. And with post-operative education, twisting and bending at the waist is really enforced education-wise with back surgeries. Okay, I'm gonna do a couple more questions. So a nurse is admitting a client to the surgical unit 2 hours after a laminectomy. Blood pressure is okay, heart rate's okay, respiratory rate, 5 out of 10 pain, that's not bad. Surgical dressing is clean, dry, JP is in there, 15 milliliters of serous sanguineous fluid. What do assessment finding requires the most immediate action? 8 out of 10 pain, toes. What's the client's toes on the right foot have delayed cap refill of 4. The nurse surgical dressing is now damp with clear yellowish fluid. And then the client reports difficulty moving the big toe and decreased sensation on the top of the foot. So what are all of these problems? Yeah, I would say yes. So surgical spine, fluid leakage, that's probably C. Decreased cap refill means they're not getting perfusion, but also the big toe, all of it means difficulty with perfusion. So the answer is actually D, just because there's lack of perfusion. There might be swelling at the surgical site, so we need to address that first, and then you can address the rest of it. So this means that they have no sensation or anything, or they're losing sensation in that foot. Pardon me? Well, cap refill, that's perfusion blood-wise. Do you see cap refill? C is, wait, what did you ask me? Oh, B and D? Cap refill, that's not a big difference, but if they're losing sensation complication would you expect? Because what are the if you were suspecting a DVT, what are you gonna expect to see in your assessment? Swelling in the leg, like pain behind the knee, redness behind the knee. Spinal cord edema would probably be D on the other question. And what about spinal cord leakage? Spinal cord fluid, CSF leakage, is looking at the dressings. So recognize those complications, because we'll have a question like this where it says, hey, temperature is this, maybe white blood cells are this, or you're testing surgical dressing and you notice you tested for glucose, so we're gonna give you the explanation, but you have to figure out the answer, which that one would be easy, which would be leakage of the cerebral spinal fluid, if it was a glucose strip. No, we're not testing the number, good question. We're not testing how much glucose. You know the dipsticks for urine that test for glucose? Those just test if there's glucose in the urine. We're not testing the number for glucose, so we're just testing if there's glucose. So you just put a little strip on there and on the dressing and let it absorb the fluid, and it will notify you of any kind of glucose. So which statement made by the client 1 day post-laminectomy indicates further teaching is required? So post-op. So my spouse can lift and move my legs to help me get out of bed more easily. I will be careful to keep my spine straight in log roll technique when I turn. I will ask the nurse to help every time I will get out of bed. I will not bend over to put on my shoes or twist my body. So which one, what, are we looking for the right answer or the wrong answer? So the wrong, because which statement indicates further teaching is required? So look for those key words, because we'll say it like that, or when would the nurse intervene? That's the other way we'll say it. So read those questions. If you're going through, you're right, it's A, because B, C, and D are what we don't want it, are what we do want to do. If you're going through a question and you're like, well, that we know that's wrong, but B is right, C is right, D is right, go back and read the question, because you probably missed that indicates further teaching. Because there's a lot of students that I did meet with, they do forget, they do miss, they read the question too fast, and they miss what it is. Okay, can we get on back hand? We're gonna move on to meningitis. So this, inflammation of the meninges, that cover the brain and the spinal cord. It's usually caused by infection or virus or something like that, but it does, cause increased intracranial pressure. So risk factors, for viral meningitis using, just aseptic, issues, measles, mumps, herpes, eborovirus, which is a West Nile virus, fungal meningitis, septic, meningitis, immunocompromised. If you lab personnel, think about all the people that are testing that cerebral spinal fluid. They need to be diligent about their safety precautions when testing things. Military, traveling to areas where they have a high population of meningitis, and then overcrowding living conditions are risk factors. So your symptoms of meningitis: headache, fever, nuchal rigidity. Nuchal rigidity, it hurts when they cannot put their chin to their chest because it hurts so much. Altered level of consciousness. Do those look familiar? Confusion, disorientation, lethargic because of the increased intracranial pressure. Positive Kernig-Rudinski sign, we're gonna, that will be the next slide, we'll talk about that. Photophobia, sensitivity to lights. This red macular rash, I joked today that if it was Halloween, I was gonna come with a macular rash on my face. Because I'll tell you in a minute. Restlessness, irritability, seizures, and then cranial nerve dysfunction. So here are the reflexes. So this first one to the top left is the Babinski reflex. So normally, an adult, you stroke the sole of the foot and our toes don't flare out. Usually between the ages of newborn to 2, their toes flare out. That is a normal reflex. But if that happens in the adult, that's an indication of meningitis, one of the tests. Rudinsky is another one where they're laying down, they put their chin to their chest, and their legs bend up. Their legs will bend and come to their chest. The other one is Kernig's, where the patient is laying flat and you lift up their leg and try to straighten it up like in the picture, but it doesn't, it's too painful and the patient can't do it. And it's all because of the spinal cord inflammation. It's too painful for them to stretch their spinal cord, and that's why they're having the pain. There's a patient that, well, there's 2 patients recently that I was talking to one of the nurses last night, and she said that someone within the last couple months came in and it was suspected, and they were doing like the Kernig sign, and they were trying to, how do you suspect it without doing a lumbar puncture, or how do you test it? So they were going through all these signs. And then we had another person yesterday that it was suspected, but they still didn't do a lumbar puncture, sorry, because you need to get that fluid to test it to confirm it. They were at droplet precautions, yeah. We'll get into it there, nursing interventions. Any question about these signs? You will need to know these signs. Diagnosis. So diagnosis with bacterial meningitis, because bacterial meningitis is a medical emergency. So we really need to identify it as soon as we can. Take precautions. We're going to take precautions no matter what. But with their cerebral spinal fluid, it's cloudy. They have elevated white blood cells. They have elevated protein, decreased glucose in it, and then elevated cerebral spinal pressure. Oh yeah. Then you could do viral or protozoa. You could do some testing to see what kind of bacterial or fungal items are in there. CT, MRI, because you could see is the intracranial pressure from an abscess or what is happening within the brain. Cultures, we need to do that. We need to check urine, nose, and throat because you're kind of ruling out other causes. And then you'll look at the CBC. And here's one more. Chest x-ray. You're looking at the sinuses and all that. Usually catheters that have hooked up, like, I don't want to say it's like blood pressure, but when you are testing intracranial pressure, they have special catheters that go in and like can measure the pressure. Yeah, kind of like an arterial. So the difference between viral and bacterial, viral is more common. Turn that off. Is it my phone?
Yeah.
Was that my phone making? Didn't get peak, I haven't had peak work. Okay, that's nice, do that. So viral meningitis, that is most common, and with viral meningitis, we're gonna treat the symptoms. Remember we talked about viral pneumonia, we're just treating the symptoms because it's not caused by bacteria. So the cerebral spinal fluid has no organism in it, so there's no exudate. So it's not, the cerebral spinal fluid is clear. And like I said, we treat symptomatically. When it gets into medical emergency bacterial, it is caused by an organism and it does increase intracranial pressure. Because there's exudate, I wanna say it's like pus that's in that cerebral spinal fluid. So to test that cerebral spinal fluid, we're gonna do a lumbar puncture. A lumbar punctures is they're gonna put in a catheter or a needle into the area, usually between 3 and 4, L3 and 4. They're gonna put it in the fluid and draw back some of the fluid. I don't wanna say operatively, but pre-procedure, keep the patient NPO, sedative can be given, have them laying on their side like this sideline position. You want their back hunched over because you wanna open up that spinal cord cavity, or they can kind of be sitting up and leaning over the bedside table. There's 2 different ways here. The knees are to the chest. Have them empty their bladder, because if you empty their bladder, they can get hunched over a little bit more. Post-operatively, we want their head of bed usually below 30 degrees for 3 to 8 hours. So they're lying flat usually for up to 8 hours because we don't want to manipulate that where they inserted that needle to get the cerebral spinal fluid. Have them drink plenty of water, plenty of fluids, and not always monitoring vital signs and urine output. A complication of lumbar puncture is a headache, and that headache is from the decrease in cerebral spinal fluid. But the more fluids that they drink, it should regulate itself. If you have any thought that a lumbar or someone has intracranial pressure, that lumbar puncture is going to be not done. And that is a nursing, we're the ones that are gonna be the first ones to recognize it, so we need to notify the doctor. That'd be something that you notify the doctor and say, I'm having questions about this, because the patient is restless, they're irritable, or they are showing signs of intracranial pressure. So you don't wanna do that, because if there's pressure already within the brain, and you're going into that spinal cord and taking some of that fluid out, so all that pressure is just gonna come right down and you're gonna have brainstem herniation. So that is why it's severely contraindicated. And I think I talked about the other one. Headache is lines. So interventions, prevention is one of our first things. You can get the pneumococcal vaccine. It decreases the risk of any kind of central nervous system infection. There's more kids are getting it usually when they enter like middle school and then high school. I remember when my son, he must have got the first one, but I think it was when he got into high school, they're like, he can't come, and I'm like, why not? They're like, he needs to get his second dose, and I'm like, he's got all of his vaccines, but I was not the good mom and took my kid to the pediatrician every year. He was fine, he didn't go to the doctor every year, so we had to hurry up and get a vaccine. And if you talk to them now, vaccines are what causes all the problems.
How long does that last? I mean, I have the kids do it like in high school and everything, but I don't know that I've ever had one.
No, exactly. Well, it's only recommended for like the adolescent years and all that.
And then after that, will they be susceptible then as an adult? Again?
The research says not if they have the vaccine.
Okay.
But we have not had to have the vaccine. And I'm trying to think of how long this is. Well, he's 23, so this has been going, because I don't think my daughter's got this.
Okay.
So it's fairly recently, it's kind of like, there's no, we'll have more research later. So, but they have research that the vaccine does help. More to come. Kind of like the COVID vaccine, we won't know anything for another 10 years. precautions. Because if you think about it, somebody come into the ED, how many people are in that room? All those people are going to get exposed to it if they don't have the proper precautions right away. So put them in droplet precautions, and then do an antibiotic, and usually a broad spectrum antibiotic is Rocephin, so we'll get that started right away. And then after 24 hours or so, they can usually go to or they're not showing any symptoms, they can go into standard precautions, Tylenol to reduce fevers. We do have to report it to the public health department because they're gonna do the community tracking, where was this patient, where did they get it, all that kind of stuff. Monitor for intracranial pressure, seizures, because anything that's going on in the brain, there's inflammation in the brain, makes them susceptible to seizures. Replace any fluid or electrolytes, because also we're gonna monitor for diabetes insipidus, because of intracranial pressure. All those complications that I talked about last week are the same for this week. So our complications for neuro are kind of nice because they're all the same. And then I talked about fluid or electrolytes and all that. So other interventions, we talked any kind of level of consciousness changes, vital signs, neurological checks, monitor for pain, give fluids. Again, head to bed above 30 degrees because we want to promote venous drainage from the brain. Decrease environmental stimuli, quiet environment, no bright lights, not a lot of noises. And here's the complications that I talked about. These are, I think I just copied and pasted the complication slide from last week to this week. So we're just monitoring for intracranial pressure. Check your electrolytes with your diabetes insipidus and SIADH. Check out your urine, looking at the urine output. Septic emboli, seizure activity. Okay, got meningitis, it's a medical emergency. Will that be on the test?
Yes.
Yeah.
Medical emergency, will that be on the final?
Yes.
All right, client was diagnosed with bacterial meningitis, is receiving care, I think it's this way. The nurse assesses the client neurological status every hour. Which finding would the nurse report to the healthcare provider? Fever, headache, Glasgow coma scale 15 to 13, or exhibits a positive Kernig sign. They already have bacterial meningitis. I would say C, because here's another type of thing, is if you have a diagnosis as bacterial meningitis, are they probably gonna have this already? So so we can throw that out because they probably have all that. Headache, do we really care? They're probably gonna have a fever. So their level of consciousness is decreasing. Even 2 points is not a good indication. Pardon me? So is headache a sign of increased intracranial pressure or brain bleed? Brain bleed. I don't want you guys to confuse that. So a headache is like the severe worst headache of my life is more of a hemorrhage, aneurysm, rupture. Don't get that confused with intracranial pressure. The intracranial pressure is a level of consciousness and the signs and symptoms of increased blood pressure, low heart rate. All right, the nurse is admitting a 6-year-old child with suspected meningitis. After placing the child in a private room, what is the nurse's priority? Prescribe a broad spectrum antibiotic, initiate strict and maintain droplet precautions, obtain a complete vital signs, and then ask about the child's vaccination history. B, we want to limit exposure, so that is our priority. Then we would go to A.
Are these all from ATI?
Pardon me?
Are these all from ATI?
I might have mixed
be like any other like surgery before we start antibiotics, so we need that lumbar puncture before.
We don't wanna halt the, broad spectrum antibiotic. So we would do that before, because nowadays you see people that are like, oh, we suspect bacterial or we suspect meningitis, and they've been here for 3 or 4 days, and you're like, any lumbar puncture, any kind of, check that? None of them. The 2 that I know recently, they didn't do one. They might have thought it was viral, maybe that's why.
So start the process.
But put them in droplet precautions and then start the broad spectrum antibiotic. Lumbar puncture will come when they do it.
That would affect.
And flex spies do this. What?
That would affect the result.
Well, it probably could affect the results, but we're looking at the rest of the population. We're looking at it being a community problem with the droplet precautions. Because we had someone in the children's a couple of years ago, I want to say, came to a hospital, was transferred to children's, and they had bacterial meningitis. So our hospital got notified and it became, it's not a big deal, but it becomes an issue with the health department. 110 degrees, that's pretty hot.
When are we gonna study?
He's in a private room already. He's in a private room, that doesn't mean that.
Oh, we don't watch the lectures, cause you.
We wanna protect everyone from in that room, and that's why we put them in droplets. Priority 1, droplet
What's that?
priority 2, get that receptor, or the broad spectrum antibiotic.
I know it's last minute, but Tuesday might be great.
Yeah, because they've been with them, it's
Okay.
Christmas.
Because I'm going to my daughter's. Her hair had surgery yesterday, and she has to work there at work, and I'm just studying for my test. I'm like, she loves her cat. No, that one's mine. Hers is not cute, but she loves it anyways. Okay. You can come to my place if you want. If your mom wants to help us.
No, you don't wanna drag them to the hospital, you wanna take a direct route.
Because my place is right.
You monitor them. You monitor them.
Oh. Oh.
Because,
I didn't even know.
so, someone else with bacterial dexamethasone, which we know is a corticosteroid for IV antibiotic. What is the rationale for the dexamethasone? So if you're taking a test question, you're like, I don't remember bacterial meningitis, but you should. What's dexamethasone? What does that do? Okay, then go find the answer. See, so answer the question in your head and then go find the answer, because most likely you could read our test questions and answer the question in your head and then go find it. Okay? Don't try to let other answers manipulate you. So easy. Alright, cerebral spinal fluid. Okay, which combination is most indicative of bacterial infection? So we're looking at bacterial infection for cerebral spinal fluid, so bacterial meningitis. So what did I say is
A.
A, because if you go through there, we said it's cloudy, so we can throw out B and D, and then go through what's the difference between A and C, which I don't even know. Elevated, yeah. So all those. So just kind of rule out questions. Because it seems like you guys have plenty of time to think another one. Bacterial meningitis was right when I was doing this. Okay, you're doing a lumbar puncture. The nurse notes sudden drowsiness, papilledema on the fundoscope exam. What would we do first? D, notify the healthcare provider and question the so we're doing a lumbar puncture. How do we want the patient positioned? Sideline on the back, right? But look at that, the back is arched, it's not hunched over. And when you're taking test questions, just go, okay, she's leaning over like that, on her side. I won't get into fetal position on the floor.
So we're supposed to be
All right, knees drawn up to the chest. So the only thing that's really wrong about A is that it's arched. Did everyone catch that? I sure did. And I have it highlighted. Sitting upright, hunched over the bedside table. And then after a lumbar puncture, we need to lay flat because we don't want to manipulate that puncture site. What's most important to prevent complications. We don't want to, because they're usually doing a little patch or closing it up. And if there's any, if we manipulate, twist, or do anything, it could open up where the puncture site is and cause cerebral spinal fluid leakage. Oh my God.
No, it's fine, we'll keep doing it.
What lab results is most critical for the nurse to check report? Oh, this is just a general. I'm just testing your skills on this one. So lumbar puncture, what do we want to check? What is the most critical lab report?
B.
So we got C, we got, what else?
Oh, wait, it would be
D?
Oh, B is in boy.
Why B?
because of the puncture.
Go back to your basics. Like, when we're doing any procedure or surgery, we gotta check our coagulation to see if they're bleeding. All right, brain abscess and then we'll maybe, I don't know. Say, brain abscess, we're gonna monitor for complications of bacterial meningitis.
In a bad
The
mood.
beauty about brain abscess is wherever that lobe is what those symptoms are. That's why I say, don't worry, or when you're studying the lobe, like brain abscess, whatever those symptoms are, it will depend on what lobe it is. So same thing with stroke, wherever the symptoms are, it will depend on what lobe it is.
Now, because it's rare, we won't be tested over this one.
Not because what?
Because it's rare, we won't be tested over this one.
To be honest, I don't remember. Usually it's deep in the cerebral hemisphere. Can it cause intracranial pressure? So maybe the question is about brain abscess, but it might be an intracranial pressure question. I don't know, I'm just pulling stuff out of my mind. But yes, the larger it gets, it causes more cerebral or increased intracranial pressure. Results, surgery, because the surgery, maybe there's an infection and that's what's causing the abscess. Penetrating head injury, and then any kind of piercing or anything in the oral cavity are indicating that an infection can occur. Treatment is, again, assessing the neurological status, intracranial pressure, any kind of blindness, because then we're looking at the occipital lobes. Are they lethargic or confused? Do they have increased intracranial pressure? Seizure activity, because now we're talking about the brain. Anything can happen, anything that's going on with the brain could increase the risk for seizures. Treatment is antibiotics, anti-epileptics because of seizures, and pain medicine. They can do surgical removal, and then we'll go, if they do surgical removal, we'll go back to the lecture last week on the supratentorial. We didn't talk about that. Supratentorial or infratentorial. How do we care for that patient post-surgically? Right? Do you remember how to do that? Pardon me? Yeah, the head of the bed. How do you know supratentorial? What is it?
Above the temporal line.
Above the tentorial line, so where's the head of the bed? Up. What are we gonna be all crunched up like a lumbar puncture? Or are we gonna be straight and dry?
straight line.
Because why do we want that?
Pressure down.
What are we promoting? Well, I said it 10 times.
To go down.
The drainage.
Promote venous drainage. Okay. You guys know that. You know that, right? Alright. Encephalitis can be life-threatening. So this is damage to meninges, or not meninges, I'm sorry, to the brain tissue. So this is kind of this is a rare occurrence. It causes personality changes, again seizures. It depends on what area of the brain is affected. At risk are children, anyone, I would just say anyone that has an immune problem or viral infections. There are acute stages with infection that it directly affects the brain cells. And what is happening is our brain cells are now producing the exudate and like pus within the brain that is causing the problems. After it invades the immune an immune response is, or I should say inflammatory response is activated because it is an infection. And you think about infection, it gets inflamed, it gets red. Well, that's what's going on with the brain. Demyelination occurs so that myelin sheath, remember I talked about it last week, that carries signals from cells to cells, that shiny part.
Mm-hmm.
I got a picture when we get to MS. So those start to degrade. So if the myelin sheath is degrading, then those electrical signals from neuron to neuron are not transmitting. So it might hit a point where there's no myelin sheath and that signal stops. So that's why you have those sensory issues and motor issues. They can develop cavities within the brain. So like I picture it as an abscess where it's starting to degrade brain tissue and you start to develop cavities where there's no brain or dead necrotic dead tissue or necrotic brain tissue. So there's three types of causes: herpes simplex, arthropod form, which is more like mosquitoes and ticks, and then I'm not even going to attempt to say that, but it's called mad cow disease. We did have not this summer, but last summer, there were some instances of mad cow disease within the Dayton community, I'll say, Broad, Ohio, Central community. I don't know how broad, but we did start getting some emails and some announcements that there was suspicion of mad cow disease within the area. But with all of encephalitis, it causes intracranial pressure. Again, wherever that it is developing in what lobe of the brain is, those are the symptoms that you're going to have. Okay, let's take a 10-minute break because then we're going to get into seizures. Let's come back at 10:09.
Arthropod? What? Ticks and mosquitoes.
Yeah, that's how I would think about it too.
Yeah.
I think Fred, you had a question on that.
They give me,
Unless I
they're
just-
so dumb. Like, they'll give me the same question sometimes twice.
Twice, right? When you put
Within
it
a
in,
20, or because I'll do 10 at a time, and sometimes it'll
I've seen that
in there
too.
2 times, and it's one that I've already answered correctly like 10 times. I'm like, well, thanks for the easy ones, but am I learning anything when you do this? Seriously,
I think I did.
I need to study for this test. So her cat, it's a male cat. It was a male cat.
It died? It turned into a female? What do you mean?
So he got crystals, which would be like having kidney stones, but a cat gets crystals. And for some reason, male cats have really thin urethras because their penises are really tiny. So he got crystals and it got blocked. So she took him in and they figured out what it was and they did a catheter and drained it and found all the crystals and he's like, okay, send you home. Put him on a different diet, and he was blocked again within a week. We took him back in, and that time he'd been in a lot of pain and it was blocked really bad. She had to take him to emergency vet, and they're like, "Oh man, he's blocked really bad. Like he's been chewing on his little pee here, and there's like necrotic tissue." Because he was so like desperate to pee or whatever, he chewed on it. So they couldn't get the catheter in, and they're like, "Well, he's gonna either have to have emergency surgery or we're gonna have to put him down." And about that time, the vet was able to get the catheter in. So the surgery it's called PU surgery, and they go in and they move the urinary. They take out his penis completely.
They took the whole thing out?
Took the whole penis out, and they move it so that it's like a female cat, so that it just comes out of a little hole. And like the risk is
So
like
he's a sheep? What do you call
his name was Lou, and she's considering calling him Luis.
so he won't be able to conceive?
Well, he was already fixed.
Oh.
And maybe possibly when he got fixed, they messed it up. I don't know. But they took off his balls. I told her, I
His
said,
walls?
balls.
They took him out too?
They took them all off. I was like, we should call him Nutless, not Luis. Poor little guy.
Why is it
It's a terrible looking surgery. So they had to like completely open him up on his backside and remove the balls and put the urethra hole in a new spot. But it is actually doing better now.
You called it it?
Well, I mean, I guess his DNA says he's still he, I guess. He probably wants to be. He has a little sister, and he is constantly trying to help her. So now I'm like, hee.
Oh, he had
Well, he does
cats
have.
do that?
It's not actually his sister, but that's what they call it.
Oh,
Because,
but it was just
it's their
another
boy
cat that
and
they
their
had.
girl cat, and the girl cat was bought a lot later than him. So when my daughter first moved out, she got Lou because he was an all white cat. She
I've
already
never heard of cats going through.
Oh, actually, they said it's like really common. There was
I'm
a
not a
surgeon.
pet person. Like, I don't have pets, so maybe that's probably why, 'cause I don't really have pets.
She sent me a picture of his surgery. Actually,
Hey,
she said he's been away.
you did good on your quiz?
Did you?
No, huh?
Yeah, I got like 3.9 or something. I missed 3.9. I missed something. I don't know
I
what.
didn't even know.
I know you can't tell.
I hate it because I don't know what I missed.
I know. I need to go and ask about all of them, everything I missed before I take the test. So I'm like, what did I do wrong?
But
So
the
I know when I
questions
go
on
do
the
my
quiz are
test.
way harder than the test.
What's that?
I didn't want to tell you why you miss.
Yeah, you can if you schedule a time, but you have to schedule a time to go see them, and they'll show it to you. You just can't go look at it yourself. Probably that way you can't tell other students. You know.
But you would think they would open it after it's due. So after 8:30.
Except for then, we could literally go in and copy paste and send
Or
it to the
just
next
review it in
semester
class.
students. Nursing students talk. They will
Which you
share.
one of them?
Huh?
Which one of them?
I don't think any of them talk. I don't know what she's talking about. The lies that are coming out of her mouth right now. Oh my god, I cannot purchase these shoes.
What's wrong? You shopping?
Yeah, they just came out. They're for Christmas. And I can't buy them because my phone number is not. I changed my number with PayPal a long time ago. And I don't want to go to
Wait
my
for
phone.
Thanksgiving. The price will go up.
They're gonna go.
It's going to go down for Thanksgiving.
No, they won't go down. They're Jordan some
Still
deal.
buying Jordans?
Well, they're not for me.
Oh, right. For the kid, mine wanted Curry's. The only shoes I can wear for basketball have to be Steph Curry's.
They're rare.
I was going to the mall, the premium mall.
Those are pretty.
Let me go to my car and get them, because then I'm not gonna know what to buy. 'Cause, well, they're for my boyfriend, then I won't know what to buy for Christmas.
Oh, they're for him, not your kid. Look at him, her, it.
It's a, he is a she now. They took away his,
His
he's a she.
his balls are gone, and his pee-pee too.
Pee-pee.
Uh huh.
Why?
He just can't shoot it. He got and she's been battling for like 6 weeks.
They're like cutthroat because there's this big like jumping thing for the water.
Is this your cat?
He's
Why would she spend that kind of money?
that's how much she loves it.
Okay, I shouldn't say that. Because, like, I just spent a ridiculous amount. She's died last year, and I spent $5,000, $7,000 saving his life, so I can't really say anything.
And we're more attractive than dog people. My youngest is a dog person. She's got a dog. I really love dogs.
Okay, because I love dogs.
I get it. Like,
I had
a lot
two
of people don't
cats.
like cats.
Oh no, I love cats. I just don't. I can't do the litter box right now. I can't do it. Oh yeah, I can't fucking stand it. The smell of gagging and disgusting. Can't stand it. When my two cats died, I was like, never again. They do, but they're like $600. I won't. I have 5 dogs. I'm done with animals when they're gone.
I love my cat.
Yeah, when my animals all die because my youngest dogs are only a year and a half. So yeah, I have a good probably at least 10 years before I have all of, well, maybe 15 years before all my dogs are gone. I'm coming home. Like, I'll be a
I only have one. My daughter, and then your spot. My daughter has a. Huh?
I'll dump them.
So I was like, why do you go? Oh no, it was cheap, you know. All of them were running around the driveway, like just.
See if I can find a picture of my other ones. Here he is. This is my 15. He's massive. And we love our big fluffies, but my daughter has this like white
They're all cute. We have my sister-in-law. Guess what? One of those.
The time that I was here,
3 Frenchies.
I didn't get them. They're sold out.
Oh, the time it took you to go here.
Yeah. Stupid fucking, I hate that kid.
You gotta update PayPal right now to your
I was gonna show you something.
Look at that. Look at how many sizes that are gone. Even in the kid size. Even the kid size.
That fast? Are they like a vintage type shoe?
I just know he's
Wait, where's that from? Whose is it?
These are my sister-in-laws.
Is she gonna get? Are she selling them?
Yes, she's making.
That's what mine is. I want to make them.
Well, she has 2 for sale.
How much?
I can ask her.
I like those better.
Well, I can ask her, but she has 2 left. Oh, this is a boy. She's got a boy and a girl. I believe he's. I don't know which one, but yeah. Would you? And oh my God,
They're expensive.
they are expensive, but I can ask her.
Alright, we're gonna move on to seizures.
Okay, I'll ask.
So seizures consciousness and ability to, and behavior issues. Epilepsy is when someone has 2 or more seizures, but they're not related to like substance withdrawal or alcohol or fever or anything like that. Those are not considered epilepsy. Epilepsy are from organic causes of 2 or more seizures. Refractory seizures is like, remember we talked about refractory hypoxia, refractory hypotension. You still are having those hypotension or hypoxia even though you're treating it. Same thing here with seizures. You have that refractory seizure where it's uncontrolled by medication. They're suddenly or they're continually having seizures. The problem with seizures is it abruptly cuts off the oxygen to your brain. So that's why it's considered epilepsy is considered not epilepsy. Status epilepticus is considered a medical emergency because you're having a seizure longer than 5 minutes or multiple seizures like in a row. They might have a seizure, have like a couple minute break, and then have another seizure. So they're continually having seizures. We've had a couple patients recently in the hospital for this. So there's a number of gamuts that can cause a seizure: allergies, tumors, anything that's going really on in the brain, drug, alcohol, fever, head injury, hypertension, hypoxemia, metabolic causes. But there are triggering factors like increased physical activity, excessive stress, hyperventilation, fatigue, alcohol, caffeine, flashing lights. So all of these are triggering events. And there are new studies or studies with women where during menses can increase females from into having seizures. There are different types of seizures where they're generalized, partial, or unclassified. General seizures usually occur in, usually the whole brain is affected, or the whole cerebral hemispheres, or both, I should say. Partial seizures, it's usually localized to one area. Unknown seizures, guess what? It's unknown. They don't know, or it's unclassified. There's incomplete data. Any kind of provoke, it could be structural changes or some infection like abscess or encephalopathy or something like that, or a stroke that can cause structural damage to the brain and cause seizures. So you will need to know the types of seizure or the seizure actions. The first one is absent seizure. This is just a brief loss of consciousness. You might see blank staring, or eyes may flutter, or they might have these automatisms. These are involuntary behaviors. You might see them like clicking their fingers, maybe smacking their lips, but it's uncontrolled movements that they're doing. Those are called automatisms. Tonic-clonic is probably what most people are familiar with. It used to be grand mal seizures, where they occur 2 to 5 minutes. They might bite their tongue, they might be incontinent. Usually they're asleep. They have this post-ictal phase where they're asleep for a period of time after their seizure. Fatigue, they'll have some confusion. They'll be lethargic, maybe shallow breathing. But this type of seizure, it begins with the tonic phase, which is muscle stiffening, and then it continues to this rhythmic jerking. So when we're watching or we're assessing a patient having a seizure, we have to write down exactly, did the eyes roll back? Were they foaming at the mouth? Did they have this rhythmic jerking? Did they have that tonic phase? Because that will help a neurologist diagnose the type of seizure and treatment. So tonic seizure, so that's just like it says, like a part of the tonic-clonic, where it's just muscle stiffening for a few seconds to several minutes. They'll have loss of consciousness and some autonomic changes. Maybe they'll have apnea, vomiting, incontinence, or they might be drooling a lot. It's quicker, but they still have the tonic phase of muscle jerking and or muscle tightening and brief jerking of extremities. And then atonic is where they just have a loss of muscle tone. I don't know if those videos are on Blackboard, but this is a person that's kind of walking around and all of a sudden they just fall. They just totally lose muscle tone and they fall. And then they have like confusion following. But you will need to know the differences between the type or the seizure actions. Partial seizures, so this includes one half of the hemispheres or one side of the hemispheres. It doesn't include the whole brain, it's localized. So complex partial is the patient may want, or the person might wander around, they might seem conscious, but they behave inappropriately. They might have those automatisms, like they're picking at their clothes, they're chewing movements, they're doing something.
Is it always the same like every time or no?
Probably, yeah. They usually, if someone's having the same type of seizure all the time, they have the same activity. Simple partial is their awareness, memory stays intact, and they are still conscious. So the main difference between the partial and the general is that consciousness. So diagnosis is EEG, get those electrodes on the head. Let's look at that electrical activity. Usually, so you need to wash some nursing care that I don't even know if the book goes into it, but usually you have to wash their hair has to be clean, and then you put the electrodes on, and actually what they're doing during the EEG is trying to cause stress to the patient to see what their electrical activity is in the brain during that stressful environment. Are they going to go into the seizure? If they have a seizure, then it will show where that seizure is. We're starting to do a couple of 24-hour EEGs or continuous EEGs at the hospital now. That's kind of new the last couple, like 6-7 months, I think.
I have a question. So, obviously, like, there's a difference. Like, the 24-hour EEG, like, I've been in the room, like, when they do the active EEG, and they definitely, like, stress them out, like, flashing lights,
Yeah.
and saying stuff. But they don't do that with the 24-hour.
No, the continuous one, they don't do it because to see what happens naturally.
So they're not trying to, like,
No,
think about
because
what
your
that
technician's not even in the room during
Yeah, I
that
know.
time. They just go like, here it is, you're on your way.
So if they were to have a seizure during the EEG, would they like call people into the community or what they're doing on that? Would they just let
Yeah,
them go through it?
well,
they
or,
find out?
I mean, they're prepared to, if it gets into the status epilepticus where it's, lasting longer, then nursing care needs to get involved.
But they may just let it go if it's not.
If it's minor, if it's small amount, and they're recording it, that's the whole point, is to record that electrical
I
activity.
think one thing that's for sure though.
Yeah.
Okay.
CT, MRI, really you're just ruling out other causes. Is there something else going in the brain, tumor, abscess, whatever going on in the brain causing those seizures? Because sometimes a seizure is the first indication that you have like a brain tumor. Someone might have a seizure and you're like, oh, why are they get a scan and then there's something going on in the brain. Nursing care, what we're gonna do during the seizure is important to know. We wanna turn the patient on their side because because usually they're increased in drooling. So we wanna make sure they're not gonna aspirate anything. So we turn them on the side, protect them from injury. Because of that rhythmic jerking, we wanna protect their extremities. Do not force anything in the mouth. There used to be wives' tale about forcing a leather belt or a leather wallet in the mouth. This goes back a long time ago, but we don't force anything into the mouth. Loosen any restricted clothing that they have. Do not restrain the patient. You always want to just guide their movements. You never want to restrain. Ensure IV access is nearby, if not already in. Record the time the seizure began, their activity, and when it ended. someone is on the floor, you're out in the community, someone's having a seizure, just put their head in your lap to protect their head from any kind of damage or anything, trauma. What to do after the seizure is we want to record, like I said, keep the patient on their side, do those neurological checks, vital signs, assess for any kind of injuries, allow the patient to rest. They might have that post-ictal phase. You need to make sure that they can rest, reorient them when they start coming to, determine if there was an aura, because sometimes people that have epilepsy would say, yeah, I felt it coming on. I could tell. My brother-in-law, the fellow with tree stand, he also had epilepsy. He's a great neuro patient. But and that was one of the things after he fell out of the tree stand, I'm like, how do you know that because he kept on saying he fell asleep and he fell out of the tree stand. And I'm like, how do you know you didn't have a seizure? And one of the things was he was up after. He didn't fall in, he was not sleepy. He goes, after I have a seizure, I'm like out cold for like an hour or two. And he was up after it, so he knew he fell asleep and just fell out of the tree stand too. But, so allow him to rest, determine if there is an aura, and you can have him keep a journal of like, these are the triggers that I had before I had the seizure, to just try and record it. It's just more education for the patient for future. Record what activity happened first. Did they have rhythmic jerking? Or what were their activities? Like I said, eyes roll back? Were their extremities clenched? What happened? What bodies were involved? What were their arms, legs, whatever? Any automatisms? Did they do any kind of special movements? Incontinence. Are they incontinence? Any weakness? Were they able to speak after the seizure? Did they sleep or were they confused? So all of these things we're writing down and charting for the physicians. Here's the auras, and it's like taste, sounds, any kind of dizziness. These were a lot of the questions that we ask before, like when the patient comes through. Do they feel anything like this, or have any of this before they have the seizure? So medications, you'll also need to know about is anti-epileptic medications, because they slow the rate of neural activity. It's not a cure, it just slows the neural activity, hoping that the seizure doesn't occur. Doses are adjusted to achieve therapeutic blood levels. So someone that's having seizures, they're on medications, and say they have a seizure, but they're still compliant with their medication, they might be put on a different medication or increase their dose or something. So someone that's having seizures, their medications are monitored closely. And I think you won't be surprised that any of these medications, some of these you guys have probably given these in the hospital. Dilantin, Cerebrex, there's a lot of them. Depakote, this is another one that's, or Keppra. We gave that a lot. Gabapentin, you'll see that the rest of the afternoon. But we want to educate them, make sure they take that medication on time, take them as prescribed, don't ever double up on a dose, avoid oral contraceptives, and Coumadin, because they decrease the effectiveness of the medication. I want to go back to take them on time. So if you have a patient that's NPO, you know that they take Keppra, they take an anti-seizure medication. You want to make sure that you let the doctor know, look, this patient's NPO for this surgery, this problem, but they take this one and this one at home. And sometimes it does take the nurse to bring that to the doctor's attention to say, hey, we need to get some IV Keppra, we need to get some IV anti-epileptic medication, because we don't want this patient to have a seizure. Sometimes build up to sensitivity to the drug, and that's why they might have what they call a breakthrough seizure, and that's when medications usually change. Oral care is really this was, you know how you can do your review of what you missed on the, or on HEI, you can do that on the NCLEX also. And care, I think it was seizure medication or Parkinson's medication was on his NCLEX, and he missed that question. And it was oral care, because I was like, well, what were your choices? And they were going through the choices, I go, it's oral care. I was like, oh, okay, I forgot about that. So it was, and that was a recent question within the last year on the NCLEX. Granted, they probably have 3,000 questions or so. And be aware of drug-to-drug interactions. Citrus fruit, grapefruit is never good with medications. If you ever get a question that says what is contraindicated with this medication, if you don't know anything, but grapefruit is on there, that's probably a good answer. Alright, Nair said, do not stop them abruptly, because you can, if you abruptly stop them, you can increase the risk of status epilepticus. Which is next. So this is a seizure that is a seizure activity that's lasting 5 minutes, or repeated seizures over 30 minutes. Like they have a seizure, then stop, and then have another one. And like I said, when they have seizure activities, that oxygen level is not getting to the brain. So that's why it's so important to stop that seizure, because we gotta get oxygen to the brain. Causes of status epilepticus is sudden withdrawal of your medications, infections, alcohol, head trauma, cerebral edema, and any kind of metabolic disturbances. Treatment is establishing an airway, so that's why when we have someone we're caring for someone that has a seizure, make sure we have airway, IV access, monitor that EKG, pulse ox, and ABG results. Drug of choice when someone is in status epilepticus is usually Ativan or Valium. I think Valium gets used in the, before they get to the emergency room. If you're at a nursing home or wherever you don't have IV access, you can do Digistat, which is a rectal gel to stop seizures. To prevent, so IV Dilantin can be given IV, and Cerebrex, and now Keppra can be given IV too, because I think someone gave that yesterday. So there's only certain medications that can be given IV. You guys don't need to know that, but Versed, yeah, I mean, don't you guys usually give Valium now?
No. For kids, we get percent.
So that's not in the NCLEX, just this stuff. But yeah, I mean, the thing with the NCLEX is there might be new medications now or new protocols now, but it doesn't get written into the NCLEX for 5 years. So that's why you guys, whenever you guys practice or wherever you practice, you always gotta go back to what is in your resources. Don't do what is in practice now. I mean, some of it can be applied because it's been very
Policies.
what?
Policies.
Policies. There are other avenues if medications are not working. There's a vagal nerve stimulator where there's an actual electrode that's implanted in the brain, and they might have like a transmitter in the brain, in the neck somewhere. And they wear a bracelet, so if someone is having an aura, they know that that seizure is coming on. They can actually stimulate with a bracelet, yeah, like a giant magnet, to stimulate that nerve stimulator, and it actually lessens the severity of the seizure or takes it away completely. Education is MRI because it's a metal implanted area, so make sure it's MRI. And because they use shortwave radios, they say microwaves and shortwave radios are contraindicated with them because the microwaves interfere with the transmission. Other issue or surgical issues, you could do a surgical partial corpus colostomy, where they resect the in between the two hemispheres so that electrical signal doesn't cross over to the hemispheres. But you need to make sure obviously looking at, their EEG and make sure that that seizure is identified. That WADA test, usually they test their language during the procedure, like can they speak and, form words or memory. The WADA test is more language. No, that. Or memory. No, that just dissects the, the hemispheres, so there's no electrical signal going to the other. That, the communication crosses through the obla, in the brainstem, yeah. Remember we had that, I wanna say, contralateral, contralateral where the, signals cross. Where you have a stroke on your right side, but the left side is weakness. So general, nursing actions, monitor their, medication levels, any kind of, possible interactions with medication. Encourage them to wear an IV bracelet, IV tags, driving laws. So driving laws, usually if someone's having seizures, they're not allowed to drive for 6 months until they're seizure free. So you're playing around with the medication, to make sure that they ward off, they're not having any seizures. Follow-up appointments, educate, family what to do, turn them on their side, keep them safe, get them on the floor, and avoid any alcohol or excessive fatigue, any of those triggers. So, what type of seizure are we having if we have blank staring? What if there's a sudden loss of muscle tone? Abrupt increase in muscle tone. Tonic. What about, muscle stiffening with rhythmic jerking? Postdictal phase. Any kind of degeneral seizures, they might have a postdictal phase. Brief jerking of extremities. In automatisms. Absence, where all of them have. That was a critical thing, no trickery. And I don't know how Free Bird. All right, headaches, we're gonna move on to headaches. This will be on the test also. So there are 3 types of headache: tension, migraine, and cluster. You will need to know the difference between these headaches. The primary, is there's no identical organic cause. Secondary is if it's from another cause. So what's going on, tumor, aneurysm, that warrants further investigation or management. And this picture is a good one because it kind of shows, will locate like their symptoms of, each headache. So the first one is tension. It's a stress headache. It's the most common type of headache. It's bilateral, meaning it's the whole head. Usually they feel like there's a band across their temples, across their head. Bilateral location, like I said, both sides of the head. And that's the difference between the tension versus migraine and cluster headache. It's usually mild to moderate, and then it has episodic or chronic conditions. Usually it's in the frontal occipital headache, in the front dull pressure, and it's characterized as band-like. It could have neck pain, or neck muscle pain. They also have photophobia and phonophobia, so sensitivity to lights and sounds. When we get into the migraine, as you can see, they have sensitivity to lights and sounds. Could be stress, anxiety. They might have nausea and vomiting. but their pain is unilateral, meaning it's on one side of the head. They might have a family history of it, or they have a history of headaches. It does interfere with your activities of daily living for a couple of days. And the thing is, there's manifestations, their symptoms are the same each time they have it. So they usually know when the headache is coming on. Triggers are nothing good. Caffeine, red wine, cheese, your tyramine diet, stress, alcohol, nitrates, none of those are good things and can trigger the headache from coming on. So with the migraine, they have different phases. The first phase is called first phase, isn't that nice? Where they might have sensitivity to lights and smells. So you might, or sounds, light, sound, and smell. So that would be the first phase. Then it moves to the aura phase where the migraine might be pulsating or throbbing, like I said, one side of the head, and it usually begins in the temples. They might be confused a little bit, and that could develop between 5 minutes, 20 minutes, and it could last up to a week, they say, at the worst symptoms. Migraines can worsen with physical activity or exertion. You might have muscle pain, you might have anorexia, nausea, all those problems. And then the bottom right, there's also, usually they have vision problems. That's the aura, or the vision, they might have blurry vision, blind spots, zigzag patterns, or something like that with their vision. Then it moves to the headache phase where they're listless, they have a lack of concentration, increased sensitivity in the head, and this is where the pain kind of moves from the throbbing to the dull phase. So it gets to a dull part, and then the post-groan phase, they might be just tired, weak, cognitive difficulties, and they might have mood changes for a couple of days, hours to days. There is a migraine without an aura, and there's considering that where there's vascular changes, and one of them is really the changes from like a spasm, but the vessels in your brain are they're vasodilating and vasocontracting, or they constrict, like it says up there. And that could be the cause of the migraine without an aura. There is a status migrainous where there's a headache over 72 hours where it can actually cause some infarction within the brain. So it is important to pay attention to these and try to treat it. Patient-centered care, cool, dark place, decreased stimuli, pet a bed above 30 degrees. The treatment intervention, you will need to know about these different phases or different treatment therapies. The first one, interventions, the 3R approach: recognize, respond, and relieve the pain. But there's two different therapies, the abortive therapy and preventative therapy. They're really just described the way it is. The abortive therapy is when someone's having a headache and they, like it's abort. I'm taking this, I'm hitting that button, and I'm getting out of it. So that's the abortive phase. The preventative phase or therapy is something that you do daily to keep that migraine away. So this is the abortive therapy. So this is what we're gonna do when we medications. So if you looked in here, you could see tryptin is all in the name. So that's kind of nice for you guys. You don't just have to remember tryptin. Imitrex, sumatriptan is usually what I've seen a lot. But the problem with sumatriptan, it has a vasoconstrictive effect. So think about your heart patients, your cardiac patients with cardiac disease. If someone has chest pain and they take tryptin, they're going to have further chest pain. So because of that vasoconstrictive effect. So you really need to find out, talk to your patients, and get their health history before you prescribe it. Not that we're prescribing it, but we need to educate. But the tryptin medication, or the other one, I'll go to the other one. Ergonomics, those are other preparations, caraphate, or not caraphate, Capragot, take at the start of the headache, but we don't give this within 24 hours of a tryptin medication. So first you take a tryptin medication, it doesn't work, you gotta wait 24 hours before you go to the next phase. Migraine is another medication, but we try to avoid it if all possible because it can have a rebound effect. But with tryptin medications, you do need to know education that goes along with this because we take it as soon as the symptoms develop. Report any kind of chest tightness or heaviness in there or chest pain. Make sure because of that vasoconstrictive effect, use birth control with taking tryptin medications. Make sure that you report any kind of you probably have flushing, tingling, or hot sensation because of the vasoconstrictor effect. Do not take any SSRIs or Lexapro or St. John Warts because that can interfere with the metabolism. But the overuse of medication can cause rebound effects. So you gotta take these diligently. The other therapy, now this is the therapy, preventative therapy. We're gonna keep these away. So NSAIDs, you have other anti-electric, Tokamak can be given, but in low doses. Beta blockers you can give because it prevents those vascular changes with beta blockers, but the side effect is once their blood starts to lose their heart rate beforehand. So we gotta make sure that we just don't tell them to take it. They gotta take their pulse. They gotta report any kind of bradycardia. Report any heart failure symptoms because this will just exacerbate that problem if they're taking a beta blocker every day because of a migraine. Calcium channel blockers, verapamil, that prevents those vascular changes also. And some antidepressants can help also with low doses, they found. Side effect of this is, well, let's go back up. With migraines, biggest thing is education on beta blockers and calcium channel blockers. Dry mouth, urinary retention, constipation. Make sure they're reporting all that, or you educate them and tell us if they're having any of that. I don't know if you went over medications too much in mental health. Talk about the Pamela work, but that's our. Okay, cluster pet. Any questions about the difference between the abortive therapy and preventative therapy?
You're back to the one by, the one that was,
Do I want somebody like that? Sure.
have nasal drainage, confusion, running nose, like facial sweating, restless agitation. So when you're going through, like, figuring out the symptoms between, the different headaches, I would pick out the ones, like, when you're, like, put them in a chart and go, okay, it looks like they all have nausea, vomiting, right? So am I gonna write that down? No. Write the ones that are kind of, not hallmarks, but are different for, between them. Like, the cluster occurs the same time of day. That's not the same with, tension and the migraine. So that's one I would remember for this. Intolerance to light and sound, that's with all of them. So I wouldn't write that in down. Describe the pain as excruciating, boring, or non-throbbing. Well, migraine has a throbbing headache, but then after the headache in the later stage, it moves to a non-throbbing, but cluster has a non-throbbing. Followed by periods of remission. It could last up to 9 months to a year and then be gone for a while. So they do last pretty long. 1 to 2 hours with extreme intensity, meaning it lasts 1 to 2 hours during that day. So cluster headaches, patient education, oxygen, because they say that oxygen prevents those vascular changes in the brain. Have them up, sitting position. You could administer the oxygen for about 20 to 30 minutes. You could give tryptin if it does help, but usually it's just treating with oxygen. Put them in a dark room, put them with sunglasses, close the curtains, and talk to them about avoiding any kind of precipitating factors. It does alter your sleep-wake cycle, or you want to tell them or educate them and consistently have a good sleep-wake cycle. So if you work on night shift, it's probably messed up. So make sure they have a consistent wake cycle because the hypothalamus is involved. Okay? Any questions about the difference between all these? Because I do have some questions that we're going to go over. These questions are too long. So if someone has a migraine headache rated 9 out of 10, nausea, vomiting, photophobia, phonophobia. I've had migraines for years, but this is the worst one yet. You know what I'm missing? I'll go into it in a bit. Healthcare provided, prescribed sumatriptan, 6 milligrams, blah, 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 whatever. What action is the nurse's highest priority? Administer the sumatriptan immediately, dim the lights, minimize noise, insert an IV, assess the vital signs, and complete neuro assessment. What are we gonna do first? Before we give the tryptin medication, what do we wanna do?
4.
Yeah, 4. We wanna assess them. What if they have heart, or they have chest pain, maybe? We gotta look at that health history and any kind of neurological assessment. 2 is good to do. But we wanna figure, because we don't wanna cause further cardiac effects if we give a tryptin medication. I wanna go back, before I go to this, so, I don't think I talked about it with seizures. I talked about assessing the patient when someone has a seizure, like, even if it's just like journaling, writing out, this is what I felt. Same thing with the headache, is because that can help diagnose what type of headache you're having. Does it happen after breakfast? What did I eat that caused the headache? Because they can see a pattern. Did it happen same time of day? So sometimes keeping a journal on your headaches helps with the diagnosis. And that's so propanolol. So we're going to give a beta that true? No, because the beta blockers, what are we doing?
Take the alarm off in a heartbeat.
Preventing, so one is the abortive phase, right? So we could throw one out. I need to check my pulse daily, call the doctor if it's consistently below 60.
Yes.
But I'm still gonna continue on. I will stop taking the medication if my blood pressure drops below 100 over 60.
No.
Do we let people just stop taking their own medication?
No.
They want to.
Do you wanna talk to the doctor first before they stop taking it? I got mine. Medication, the doctor's like, you're not the doctor. Okay, I can expect to see significant decreases in my migraine frequently within the next 3 days.
No. No. It'll take longer than that to work.
But, decreased frequency, no, we're hoping that it just takes it away. So your first guess, yes, for 2 is accurate, but you still wanna go through and read all of them just to make sure that you're not missing anything. But are you gonna tell the patient, go ahead and stop it? Or are you gonna say, call me and let's discuss it? I would say, call me. The doctor's you always wanna talk to the doctor before you stop the medication. So, are you, well, you might, I know we talked about
Lunch.
EPA and those kind of, so stopping the medication, call the doctor.
Well, there's roommates in the cafeteria.
We're gonna move on to MS. So this is a chronic disorder. There's a lot of chronic disorders. I saw someone printed out something from Blackboard. It's a chart of all the different chronic disorders. I'm trying to see it. Did you print it out? It was all kind of organized. Yeah, it's a chart. Just fill these in.
ChatGPT will fill in for you.
I already filled mine out. I should have waited. That's empty. She's got an empty tray.
So just kind of go through this. What are the hallmark signs, treatments? Because some treatments are a little different for all of them.
Oh, this is so
Medication, signs and
pretty.
symptoms, any kind of special education. It'll just help you kind of organize your notes for the final
Color
intro.
coded. I should have done that. I'm gonna redo
Just
it.
tell ChatGPT that you
So
have to
MS,
do
this is
Oh, I can do the color
it
coding.
triggers
I
the
have all the
myelin
stuff in
sheath.
here.
So this is what the myelin sheath looks like. It's nice, pretty, and
I
shiny.
know.
But with,
But I added stuff.
demyelinization occurs with multiple sclerosis. So you can see that those electrical signals can't get
With Hallmark.
transmitted well. They get halted.
Like,
So, some triggers, there, I forgot part of it. It is a chronic disease, it's an immunity disease, it does have genetic factors, it can be, infectious factors can affect the myelin sheath, like encephalopathy also. But they do have repeated exacerbations of the disease, and, where that damage to those myelin sheath does become permanent. I know I think that quiz question, I haven't looked at the previous quiz assignment. I know you had to know, were tested on the different types of MS, right? Am I true on that? Yeah. Yes.
That was hard.
I have it in my notes, but I couldn't even like figure out what kind of look.
Yeah.
Like this.
So it did not match up with what was in the book.
Yeah, it didn't match up, so it was hard to like.
Sorry.
Like it was like.
I'll look at it. We evaluate all the quizzes.
Cause see, I had this. I had
So are
this.
there different,
Heather. I had this. I
types
have it right here,
of
and I'm like,
MS?
what?
Because you can have relapse remitting, which is the most common, where they have mild
just-
to
they
moderate,
worded it
depending on the degree. And then those symptoms do resolve. Primary progressive is when there's a normal state. Secondary progressive is they do have relapsing periods where they come back, but they don't come back to their full normal state of neurological status. And then progressive relapsing is where they have frequent relapses, but they still don't, they happen a little bit more and they don't return to baseline. So usually fatigue, hallmarks for them are the vision changes. And I don't even think that's on there. Oh yeah, there's the second one there. Slurred speech. They might have muscle spasticity because those electronical signals are not, there's not a smooth transmission. So they might have those muscle spasticities. Numbness, pain, emotional depression, tremors, or spastic bladder. So diagnosis, you're looking at laboratory results, cerebrospinal fluid. Are there increased IgGs, immunoglobulins, because it is an immunity attack? So that's why we're looking at your immunity properties. Imaging, we can get on the CAT scan, we might be able to see some white density matters because of those, the myelin sheath is degrading, and then the MRI can show some plaque. The biggest thing is we want to promote independence with the patients. Big thing with neuro, with these chronic conditions, risk of falls, so safety. Make sure they're safe at home, safe in their living environment. Monitor their visual acuity and their speech patterns. We're also looking at swallowing control. Do they have full muscle strength with dysphagia? Because we want to make sure we're preventing aspiration. Coping with stress, coping with, or strategies to deal with the stress. As you can imagine, they're stressed about it because usually it's the younger female generation that gets this. Decreased UTIs because they don't have the strength and ability to empty their bladder, so they'll hold on to urine. So they're prone for UTIs. So you want to encourage fluids, and it's called a Creed maneuver, where you actually put pressure on their bladder to help them empty their urine, and they can be taught that to do that at home. PT, OT, you always want to get a routine. The neurological patient is routine. Keep a routine, the same routine, don't do a lot of changes. Vision, you might have an eye patch, have them scanning the environment. Teach about getting rest. Don't have them do a whole bunch of things early in the morning, because then they're just going to be exhausted the rest of the day and might have some problems. So you want to space out their activities. Plan activities, set realistic goals, and review medications. I'm right side for today. I'm getting confused now. There's a lot of medications for MS. I know there is, but a lot of them, I would just know the categories, like corticosteroids, know the immunosuppressant agents, that we gotta decrease the immunity confusion or fatigue, they can have medications for. But I would just know the category of spasm, antispasmodic, immunosuppressant agents, and corticosteroids.
Can you go back a slide or two, please? That one? Okay.
So myasthenia, myasthenia gravis is another autoimmune disorder where you're producing antibodies on the thymus to attack the acetylcholine receptors in our body. What it produces is fatigue and weaknesses. And our priority when someone has MS, when we get into these, sides fall, but if they have produced weaknesses, we've got to worry about their respiratory center. So airway is always important too. But weaknesses increases also with activity, so make sure you take frequent rest periods. With myasthenia gravis, you might have remissions and exacerbations also. Muscle weakness will increase as the day goes on. They might have ocular weaknesses. You might have a droopy eyelid. They're prone to, now I feel like I have it because I have this voice. Aspiration, because they might have weaknesses with swallowing. But factors that can contribute to this, infections, any kind of pregnancy stress, fatigue, body temp, incontinence with medications. Diagnosis, we're looking at this repetitive nerve stimulator because they can actually see what is going on with our muscles and our nerves. So that's why a CMG, we want to look at the strength of our muscles. What kind of signals are going through our muscles? And we can do that. It's like an EKG, but with our muscles. We can also do an MRI because we want to look at that thymus gland. There are 3 crises that are pretty important to know for myasthenia gravis. The first one is the tensilon testing. So this is to diagnose myasthenia gravis. So when you are giving medication, usually, tensilon, you're giving it, and then within, you'll see improvement in muscle tone within 30 seconds to a minute. So you give the medication, and before the testing, they might have these droopy eyelids, but after they give the medication, they can open their eyes. But the problem with tensilon, it has a severe bradycardia effect. So you want the crash cart, you're going to have everything, emergency equipment nearby for this. Usually this is only tested in ICUs because of the personnel, the critical care that the patient has. They can inject it. If they have improvement, great, now we have a diagnosis. But because of the complications with bradycardia, what medication are we going to have nearby? It's certainly, we're going to have atropine, because if the patient has severe bradycardia, we're going to give atropine. The ICE test is another type of test that can help with diagnosing it. It does resolve the symptoms temporarily, but what happened is the cold temperatures decrease the breakdown of acetylcholine, and that is why they have the improved muscle strength in their face. These are kind of messed up. Well, okay, that's diagnosis. We talked about the diagnosis, the ICE test, the tensilon test. So medical management is our antipolar esterase medications. I have to look at the medications for the class to say it. So what happens, this improves that neuromuscular transmission. It prevents the destruction of acetylcholine, but it also causes bradycardia. So we need to check cardiac status of patients. Immunosuppression, prednisone. We want to decrease any kind of inflammation. Plasmapheresis is where diagnosis. Plasmapheresis is where they remove all the antibodies, the liquid portion of the blood, and then they filter it out and give the good antibodies back. They're put back into the body. So it tries to filter out all the bad antibodies, and it sounds crazy, but that's what it does. IVIG, I skipped that one. IVIG, you guys talked about it, immunity, where we're blasting the body full of good antibodies and just increasing the effects of, not the effects, but having more good antibodies in the body than bad antibodies. Surgical, you can do a surgical management where they involves removing the thymus, because the thymus is believed to decrease or inhibit the acetylcholine destruction. So I talked about the 3 crises. So here's the 3 crises. Tensilon is to diagnose it. You get a drop in heart rate. The cholerogenic crisis is when the patient is on too much anticholinergic medication. So the drug is causing respiratory distress, increased GI mobility. They might have hypersecretions, so they might be drooling a lot, runny eyes, runny nose. It does cause hypotension also. The Tensilon shows no improvement or any kind of worsening. And then the myasthenia gravis or the myasthenia crisis is just exasperation, where they're not having enough medication. That produces the weaknesses and respiratory distress. And how I remember this is cholerogenic, they have increased hypersecretions, so they have a cold, they have cold-like symptoms also. Cholerogenic, C and C, that's how I remember the difference between the 2 of them. So I know that the drooling and any kind of drainage from the eyes is the cholerogenic crisis. Myasthenia crisis is just not enough medication. Pretty much, and I associate that with, that's just a disease. They don't have any medication on board yet. But you will need to know the difference between conditions. Then I get into management again. I think these slides got flipped, but that's okay. Respiratory support, we want to support any respiration, prevent any kind of aspiration, have vent equipment. PTOT, speech therapy, because of the weaknesses, you're going to have those therapies involved. Energy conserving techniques, because remember, as the day goes on, they get tired, so teach about maybe doing most of their important activities in the morning. Space them out though, don't do a whole bunch of them. Assist with communication, so slowly, yes, no, eyes blinking. Repeat what the patient said to clarify that. Nutritional support, small frequent meals, and also giving the medication before they eat, because we want to make sure that they have full muscle strength while they eat and swallow. Eye protection, they cannot close their eyes all know it, and they're like, don't give me that. Let's see. So the hallmark for this disease process is they have ascending muscle weaknesses, and it's usually bilateral, meaning that it starts in the feet and comes upward. So, and it's bilateral. So they might have foot drop in both feet, and then it kind of progressively gets worse as it ascends up the body. And it could start, it could be quickly. It's like early in the morning, and by afternoon you are totally paralyzed. I've seen that quick response, but it usually starts in the feet and works its way up. They don't have any cognitive impairment. They know what's happening. Even though they can't speak, they can't verbalize, communicate with you, but they have, their mentality is intact. Getting down to it's just the demyelinization and the sudden, and it's usually sudden. Symmetrical paralysis, and I got the rest of it there. No, it progresses and it progressively gets worse. So identifying it, and sometimes, one that I'm thinking recently, they were transferred to a bigger hospital, and then looking at the history, you could see that they had COVID a couple months ago, and I'm like, this is like hallmark for Guillain-Barré, but it wasn't. I thought it was. I had to think about where I was working and how do I know all this information, but it was literally hallmark for, they were in rehab for this, and then I was looking at their history and going through notes, and I mean, it just all of a sudden, it happened very quickly. Within a day, they had motor weakness on their feet. By the end of the day, they were on a ventilator because their respiratory, their diaphragm got affected, and they were on a ventilator and they were in rehab to get stronger. They will survive. It could take a year for them to they'll regain function and all that, but it could take a long time. And then diagnosis, you're looking at cerebral spinal fluid, looking at the symptoms. Sometimes you're just looking at the symptoms, figuring out what's going on, looking at their history, MRI, CT treatments. Again, plasmapheresis, and so this is the picture I was talking about. They're removing blood, filtering out all the bad stuff, and putting the good stuff back. IVIG, we're blasting the body full of good antibodies. And you can also do cerebral spinal fluid filtrations also. Other treatment, care, respiratory, we gotta watch with our chronic neurological patients, we gotta watch their respiratory. Keep making sure that they have deep breath sounds, because if you have a chronically, like MS, Guillain-Barré, or something like that, if you have a patient like that, and you're starting to see like shallow breath sounds, like they can't take a deep breath in, that's a concern, because that means that they're not supporting they're kind of progressing, because they don't have the muscles, that diaphragm is getting weak, that can't take a deep breath in. Monitor vital signs, EKG, pain management, opioids, gabapentin, any kind of antidepressant,